Hello, everybody, and welcome to another Thursday Night Live. Today we have Dr. Yudith. She graduated with honors from Sydney University in 2003. She loves treating children. Her favorite rotation as a resident was pediatric dentistry. Dr. Yudith's interest in orthodontics began when she worked in a country practice where orthodontic services were limited. She has learned from respected clinicians in the field, such as Dr. Derek Mahoney, Dr. Skip Truitt, Dr. Chris Farrell, Dr. Chris Chang, Dr. Ivan Malagon, Dr. Diego Pedro, Dr. Stephen Olmos, Dr. Simon Wong, and others. She believes that education can empower and inspire both children and parents to be their best selves. Dr. Yudith has given talks to dentists, speech therapists, and other health providers. In addition to orthodontics, Dr. Yudith's other interests are in laser dentistry. She's a fellow of World Clinical Laser Institute. Welcome to Airway Circle. Thank you so much for being here. Do you mind sharing with everybody how we met?
Hi, yes, Renata came to our practice some time ago and I got to show her around. And she was very interested when I showed her how I treatment plan a patient. And yeah, this is how we started.
Yes, I was blown away. I was like, please come share this. I mean, you guys are treating kids young, and I cannot wait for your presentation today. So you're welcome to go ahead and share your screen with us, and we'll leave all the questions for the end.
Okay, here we go.
Thank you.
So my topic today is guiding faces, and it will be a brief overview of dentofacial orthopedics. So we've all have seen faces like this on television, and in our community as well. A lot of these faces are actually Australian celebrities. I don't even know who they are. I just got them from the internet. But we are seeing this as common things now, like, retrusive chin, underdeveloped maxilla, so common that we think it is normal. And we also have been seeing these kind of faces too. And unfortunately, we don't think this as average anymore. So this kind of makes us wonder, what makes faces grow well and what makes it disproportionate? And can we improve a disproportionate face? So I'll be covering this topic. This is the textbook that we use when we're studying. So as early as 1958, we know that growth is not programmed within the bone itself or its enclosing membranes. The blueprint of growth for the design, construction, and growth of a bone lies in the muscles, tongue, lips, cheeks, integument, mucosa, connective tissue, nerves, blood vessels, airway, pharynx, the brain as an organ mass, tonsils, adenoids, and so forth, all of which provide information signals that pace the histogenic tissues, producing a bone development. And in 1975, Dr. Melvin Moss proposed a functional matrix theory. In short, bones should not be considered as the named entities in osteology, but as a series of segments. And the function actually drives growth. And Hans and Enlow also added that the growth of a structure works towards a state of composite architectonic balance among all of the separate growing parts. This means that the balance is so important, so function is not lost, because function is important for survival. So what does this mean? This means that environment influences growth. Nowadays, we know about epigenetics. In epigenetics, every gene is wrapped by a structure named the histone. And besides this histone, there's small structures which are the epigenomes. They activate the histone like a switch, so the gene can be wrapped or unwrapped. The information to switch off or on a gene is provided by the epigenomes, by the environment. Cell biology can be modified by the environment. There is now enough knowledge that cell biology is influenced by constantly changing environment and not just by its gene. So this is kind of like a tongue-in-cheek photo. You could see that this is Henry Cavill's siblings. They all have good genes, and they all kind of have that square jaw potential. But who knows, some may have better face posture than the others, and some may have better function than the others. But I thought it was funny. Okay, so because good function is so important, the aim of dentofacial orthopedic should be to unwind unfavorable growth and to create structures that are conducive to good function throughout life. And this should be supported with rehabilitation of dysfunction that in the first place resulted in disproportionate growth. Dysfunction and atypical growth. Now, the body compensates for the environment it is in, arranging itself for survival. We all have seen this kind of faces. We've seen the crooked nose, the receding chin, smaller airway, narrow face, and bad posture. So when the nose is obstructed, a growing child will breathe through their mouth. They will have their hair forward to open the airway. The muscles of the craniofacial structures that are used are different from those of nasal breathers. So the signals activating the craniofacial growth will also be different. The way the craniofacial structure grows will also be different. Another example, when there are restrictions in the oral tissue, a growing child may need to lip raise to create vacuum seal in swallowing. We call this reverse swallowing. Or they may recruit other muscles to compensate. And this activation of different muscles result in different pattern of growth. They may also gravitate towards certain textures of food. And this then perpetuates activation of atypical swallowing muscles and atypical growth. We also know that modern diet is softer. This means less chewing and oftentimes high in additives, which can cause inflammation. Inflammation means more mucus in the nose. When the diet is soft, the muscles around the face also won't expand or separate. And therefore, we get what we call now shrinking skull. It is also important to note that every 1 inch of the head forward, the neck carries 4.5 kilograms more of weight. This can lead to muscle compensation, especially the neck and the shoulder. Postural compensation of the whole body then result, and we often get pain. And children don't often tell you that they have pain. They think it's normal. That's why we need to screen children for pain too. Now, it is also important to note that we don't have a lifetime to keep on, to grow. By the age of 4, 60% of the facial growth is complete. By the age of about 6, about 80% of the facial growth is complete. By the age of 11, almost 90% of facial growth is completed. And this has been replicated also in Bolton's study, where they followed up children for as long as 25 years. Now, by knowing how structure grows, we can influence growth and unwind unfavorable growth trajectory at the right time. And of course, we need to correct the root cause, and then we need to also rehabilitate function. So these are the areas of resorptive and depository bone in nasomaxillary complex and the mandible. As dentists or orthodontists, we need to know this really well, because if we don't, then our biomechanics won't be efficient. We won't be working with growth. With the nasomaxillary complex, the general direction of growth is downward and forward. It remodels as it grows downwards and forwards. The horizontal lengthening of the maxillary arch happens at the tuberosity and is posteriorly directed. The maxillary tuberosity is the major site of growth. Now, this is why reverse pull headgear at the right time is very effective, because it follows the natural direction of growth. The anterior part of the bony maxillary arch has a periosteal surface that is resorptive. The lingual side is depository. So this is also important because when we do, for example, Invisalign, we need to know where the root should end up and how to control the root top. And then next we have vertical drift of the teeth. This takes place after eruption and is part of the downwards displacement of maxilla. This is another anatomical point that we can manipulate. For example, if we want to rotate the growth from vertical to horizontal, we can actually intrude this posterior teeth and hold the growth of the maxilla horizontal and, allow the mandibular rotation. Growth is influenced by muscles growth and displacement. Palatal expansion mimics displacement, and expanders provide tension to encourage bone formation. This is an interesting study by Angileri in 2013. He looked at 140 subjects with the age of 5 to 11 years of age. And what he found is by the age of 11, all types of sutures were found. So he took cone beam scan of all these maxilla and he grouped them. If it's straight line, then it's stage A. If it's scalloped, then B, and so forth. So if we want to do expansion, it is better for us to be in stage A or B, which means by the time they're 11, we should really think about other intervention. For example, hybrid rapid maxillary expansion or expansion using mini implants. It is also interesting to note that every 1 millimeter of transverse expansion, there's 2.35% increase in nasal volume. This is why we see a lot of slip issues resolve when we start doing expansion. Going back to the reversible headgear, we also have a window at which we can do this. People have studied the pterygomaxillary suture, and it appears to be considerably interdigitated by the age 12. So any orthodontic protraction needs to be before this age. Moving on to the mandible, the remodeling modification increases the size of the mandible as well as maintaining constant positional relationship between upper and lower arches. There are many muscles attached to the ramus, all providing signals of growth. And mandible needs to keep up with the growing maxilla by adjusting alignment, vertical length, and horizontal length. This is why when the maxilla doesn't grow well, we can see canting, functional shift, as well as asymmetrical mandibular length with unilateral crossbar. The condyle is also a major site of growth. It provides a pressure-tolerant articular contact, and it exerts a regional adaptive growth capacity in response to fluctuating circumstances, such as occlusal changes, myofunctional habit, airway insufficiency, and variation of growth. Hansen and Lowe suggested that the proliferative process in the condyle produces a backward and upward growth movement of the mandible. In fact, this was the basis of functional appliance. However, more recent studies show that the mandible undergoes complex rotational change during growth. Laher in 2005 evaluated the treatment effects of hyperdivergent class 2 patients. He found that non-extraction high-pull headgear, extraction with high-pull headgear, and herbs appliances did not improve the chin position. I have in the picture here is the herbs appliance. So it is actually a very painful appliance. Obviously, I don't use it anymore. He found that there was no difference in chin position when subjects were compared to untreated hyperdivergent controls. And why is this? Because the mandible keeps on rotating clockwise, even when the appliances displace the mandible downwards and forwards. So there is more than just simply repositioning the mandible downward and forward and hoping that the condyle will produce growth. So the first people who studied mandibular rotation was Bjork and Scaler. They put implants into children's mandible. Obviously, we're not allowed to do this anymore, but this is very useful. They compared the angle that is made by drawing the line between the two implants and the anterior cranial base, as well as the angle drawn, angle from the line drawn from the two implants and the lower mandible tangential line. and they confirmed that mandible undergo complex rotational changes. Bouchang and Jacob then took this even further, and they did multiple regressions on large samples of children, followed up longitudinally. They wanted to know if the AP chin position, anterior-posterior chin position change, is due to the amount of changes in the gland fossa, or vertical and horizontal changes in condyle, or mandibular rotation. And they found that true rotation was by far the most important variable. So we cannot ignore rotation. When we treat patient, we have to respect that the mandible is going to rotate, and we need to know how it will rotate and what makes it rotate. The same group of people also summarized the finding from previous studies using implants in mandibles. They found, this is Bouchang and Jacob, they found that most true mandibular rotation during childhood occurs during transition from the late primary to the early mixed dentition. This means that the dentition plays an important role in controlling rotation. And we can, to a degree, control where this dentition is going to be. The greater amount of true rotation is caused by changes in the anterior dentoalveolar height. So if we have reduced anterior dentoalveolar height, then the mandible will rotate counterclockwise, therefore making vertical face more horizontal. Again, we can control this too. Mandibular posture directly influences changes in the position of teeth, remodeling that occurs on the surface of the mandible, and the growth that occurs in the condyle. In hyperdivergent patients with compromised airway and weak masticatory musculature, the rotation is backwards. So what this means is if we're treating this kind of patients, we need to work on their muscles. We also need to look at the airway and work on that. Otherwise, they will keep on rotating backward. Doesn't matter what you do. It has been well established, both radiographically and histologically, that there is no apposition of bone on the tip of the chin. So to improve the chin, one is to encourage counterclockwise rotation of the mandible. This means mandibular rotation is really not negotiable. So if you want to improve the chin position, you can try to reposition the mandible downward and forward. It's not going to happen if your rotation is still the wrong way, because the bone is not going to grow there. So let's put it all together. Not only we need to address the root cause of malocclusion, we need to play by the rules of growth. In maxilla, we can influence mid-palatal sutures, pterygomaxillary sutures, and vertical drift. So it is not so much the appliance we use. I use a variety of different appliances, from clear aligners to removable plate, but it's more about how the appliances are used and how we do the mechanics of the treatment. In mandible, we need to respect the rotation of mandible, and rehabilitation of function is important. There's really no use of creating good structure, but then the muscles cannot really work properly with it, because the children, by the time we finish, they're still growing, everything will get undone. So this is the typical team in the treatment. Of course, we have the parents. They're more like the coach in the treatment. And of course, if we have activation of appliances, they play a role in that too. We always have ENT, breathing educators, sometimes an immunologist or sleep physician. We also have body workers, OMT. OMT is very, very important. I think I will not get any result the way I do if I don't have their support. And of course, we have us, dentists or orthodontists. So let's go through 2 cases. So this is SB. She's 8. Well, she was 8. She presented with face asymmetry. She did have a head tilt. The eyes and the ears level were not equal. And the cheek line and the nose lines are not parallel. So the cheek line is kind of a quick reference to see how the direction of growth is compared to the rest of the face, which is like the nose. So we always do BSQ for all our patients. So this is a pediatrics sleep questionnaire. So her score was 3, and it was a heavy breathing, easy distraction, and does not seem to listen when spoken to directly. So it's more both breathing and behavior. She also presented with reverse swallow, low tongue posture, open mouth posture. There was no feeding issue, but she had occasions of glue ears. We also suspected chewing on one side more than the other, but the family wasn't sure. And as we will see later on, she also had narrow upper arch, flattened lower arch, and ankylosed lower ears. She also has bilateral posterior crossbar. There were some restrictions of the upper and lower lip ties. They were previously released by different provider. Sorry, I'm not sure how to make this disappear. Let me see. All right, so I could see that there's a question about the rotation of the mandible. All right. I'm having a problem with the mouse. Oop. Let's see. I'm so sorry. Just having a problem with my mouse at the moment.
You are fine. This is absolutely wonderful. We've been talking recently a lot about the mandible. And
Yes.
I feel like you're answering a lot of these questions. More questions are coming up. You let us know if you want me to ask something now.
I cannot. Yeah, you can ask me now. I was just trying to figure out how to make the chat box disappear because obviously the audience might be seeing that and
No, they're not.
Okay. You can ask me now if you want.
Sure.
Or you can ask at the end. It's yeah, whatever suits.
Did you get the mouse to work?
No, do you mind if I just go get my mouse? Because I'm just using the.
No, go ahead.
Okay, so this is the pediatric sleep questionnaire that we give to all our patients as part of their workup, obviously. There are other options as well that other practitioners use, such as the Bear Sleep Screening tool. We currently don't routinely give the children sleep monitor. Yeah, because they don't tend to find it comfortable, firstly, and secondly, it doesn't really change our management. It's a different story when they come from a sleep physician. Then obviously the sleep physician already provided us with this information and they always review the patients once we are done. So this is SB. This is how she presented the bilateral posterior crossbite. She did have some functional shift, as mentioned before. And this is the shape of the upper and lower arches. So you could say they're quite flattened and they're quite narrow. So the family main concern was the bite, obviously, because she was one of 5 siblings and she did look different from the other siblings. So this was the self-analysis. As mentioned, she has underdeveloped maxillomandible bilateral posterior crossbite. The point A was behind the anterior arc in Jefferson analysis. So point A is our reference for where the maxilla is in relation to anterior cranial base. She was class 3, mid-face deficient, and is a horizontal grower with some growth remaining and some enlargement of adenoids. Another interesting point here is I often, we have an iCAD machine in the practice, and when we take images of these patients with breathing issue, they almost always have like their head forward like this. And I often also see subluxation of the C3. But anyway, I think it will be feasible on my next case. You could see a little bit here. But yeah, I don't have a pointer for my mouse, unfortunately. Okay, so again, the low tongue posture and adenoid hypertrophy. And I did mention about the head position. Oh, there you go. You can see the C3 subluxation. So I see that a lot with patients with breathing issues. So this is her OPG. The canine teeth on the upper are not in favorable growth trajectory, and we did have ankylosed lower E's. We could also see inflamed turbinates. We have fullness of the right hand side sinus and deviated septum. And there we go. The deviated septum is highlighted with the arrow. The upper arch has a stage B, scallop height density, so we're good to go for maxillary expansion. There's some functional remodeling of the superior border of the right-hand side condyle, and we have less space here. So in our consults, we don't worry the patients or the family too much about TMJ, but one of our goals is to create good position of the TMJ to prevent them from having problems later on in life. Yeah, as mentioned, the right-hand side condyle needs to move forward and to the left a little. So these were our goals. We wanted to address breathing, orofacial dysfunction, and posture. We wanted to unwind underdevelopment of the craniofacial complex. We wanted to bring point A forward, develop upper and lower arches, and encourage mandibular rotation and control vertical. And then we want to support transition to proper function, which means retainers, until good functions become habitual. So this is what was done. We referred her to ENT. The ENT confirmed adenoid enlargement, but they decided not to do anything for now because she didn't have any snoring or bruxism, even though, as we know, she did have some heavy breathing. The ENT suggested Nasonex and dust mites allergy management and deviation of the septum to be corrected at 15 years of age. We also encouraged diet and lifestyle changes. We wanted to control inflammation. She did have OMT and postural exercises. This patient has had tongue tie, upper and upper lip tie released when she was younger. She also had body works as well. The whole family sees chiropractor regularly, so it was quite easy to integrate. She did have upper bioblock stage 1 with reverse pull headgear and lower Williams. The reason why I use lower Williams, which I do not use often here, is because I wanted to put a lower hook just in case I want to run class 3 elastics, but I really don't like running class 3 elastics because it may potentially cause the condyles to move even more posteriorly. As it will be evident later on, I didn't need to use that because she was very good with her posture. She did have oral postural exercises to increase muscle tone and, again, OMT support. And then she had 6 months of retainers to transition to myobrace and then her own posture. And then she did have reevaluation of PSQ and reevaluation of the orofacial function and posture. And then she was planned to have reviews. I think she's only had her first review not long ago. And then these reviews normally are done every 3 months until all permanent teeth have erupted. So these are her appliances and the reverse pull headgear. So the appliances can look very cute too. And this is after 6 months. We could see that the eyes are leveling, the ears are getting a bit more level, and even the shape of the face has changed. We could see the cheek line has improved, is more parallel to the nose line. This is what the bite looks like inside. So she's a bit more centered. The crossbite has disappeared. And this is the upper and the lower arches. So we're getting more room for the incoming adult teeth. So at 12 months, we finished. She was still continuing on with the OMT, and she was still seeing chiro. She was still being reviewed by ENT for her allergies. But we could see that the face looks so much better. This is what the bite looks like. We have the ankylosed lower E's and lower, no, actually just lower E's. So we are monitoring it. And this is what the arches look like at 12 months. So better shape. And this is on the first review at 18 months. So the face looks so much better, more even, more symmetrical. I think her forward head posture has returned. The cheek line is not as parallel, but very minor details. So from the previous meeting, I said to the mom to keep her up on the OM. And you could see the tongue is slacking off, it's starting to kind of splay over the teeth. And the lower canines are erupting into place. And this is the before and after. So you could see there's more fullness of the cheek. The forehead contour is different. And we have managed to keep the face from growing longer. So this is the initial analysis as a skeletal class 3. And this is at 12 months, so normalizing. This one here is, at 12 months. So there was still further rotation of the mandible. Hopefully I did have it. So she was getting ENT review, and ENT requested new CPCT scan. So I took the opportunity to check the Ceph as well. And as you could see there, she's more well proportional and well balanced. And these are the 3 comparative radiographs. And yes, we are still keeping an eye on the ankylosed lower E's. So my protocol is when the lower premolars are sort of halfway formed, then I would think about removing the ankylosed teeth. So before and after, and before and after. So I have another case to share. So this one here, she was 9.5 when we started. There was head tail rotation, uneven levels of ears, eyes, and shoulders. And she did have quite low muscle tone. So PSQ was 3, surprisingly low. Heavy breathing. That's actually a typo. Mouth breathing during the day, grinding, and she did have some fidgeting habit with the hands and feet. She did have reverse swallow, low tongue posture, poor lip posture, forward head posture, and low muscle tone. Flattened upper and lower arches. She did have class 2 dental occlusion. She was still growing, which is nice, and mesially ungulated canines. She did have upper and lower lip ties, adenoid hypertrophy, inflamed turbinates, and deviated septum. So this was the initial X-ray. You could see the enlarged adenoids. And we could also see the class 2. We have a straight line suture again, so we are good for maxillary expansion. And we did have deviated septum as well. This is a picture showing the low tongue posture. And the family's main concern was the overjet and teeth grinding. The mother also mentioned that the older sister had extraction braces at 14, and the mother wasn't happy with how the face looked afterwards. So she wanted something better for the younger sister. And she did saw ENT before seeing me straight after the X-ray was taken, and she had turbinate coblation adenoidectomy, and upper lip tie released. Not quite sure why the lower lip tie not done. So 6 months after ENT intervention, she came to see me. This is how she looked. So you could see the overjet. There's some evidence of teeth grinding, flattened cusps, flattened upper arch, narrow lower arch. And I think this reattachment of the upper lip tie, the lower lip tie never got done. The tongue appeared to be okay, but low tone, low posture. Let's see if I can get the video to play. So I always take functional video as well. So you could see the low tongue posture and the thrusting. You can see the tongue there. And then this, hopefully you can see a little bit later, but there's a lot of lip activity. So basically tongue thrusting, no jaw dissociation and lip raising. Okay, so the mesially angulated canines shown in the panoramic. And turbinate still inflamed, but I think that was more diet related. Again, the subluxation of the C3, I see this a lot. We could see the recessed chin as well, and the compensation from the lower incisors to try meet the bite. And the condyles, the right-hand side condyle is more posteriorly positioned compared to the left-hand side. Let's see if I can get the arrow. Nope, no arrow. Okay, so analysis. 2B, which means the lower jaw is too far back, and she's quite horizontal. Okay, treatment goals. We wanted to address breathing, address the orofacial dysfunction, which is mainly the reverse swallow, open mouth posture, and muscle flaccidity. We want to develop upper and lower arches to reduce the risk of canine impaction, and we wanted to bring the gene AP forward. So this is what was done. We did some diet and lifestyle changes recommendations. So basically reducing inflammation in the diet. This includes reducing refined sugar, gluten, dairy, processed food. And then she did have breathing and postural exercises. Unfortunately, family was not open to body work. Mother is a physiotherapist, so that was super helpful with the postural exercises and OMT work. So she basically did a lot of the exercises with my patient. On this occasion, I also used upper and lower BioBlock stage 1 expanders, followed by short-term modified functional appliance, in this case, modified twin block, and stage 2 MyoBrace appliance. And then we did re-evaluation of PSQ and orofacial muscle dysfunction. And then she will be reviewed in terms of growth and development until permanent dentition. She will continue some postural exercises just to maintain, and OMT until functions are correct. So that was her appliance. She chose the Husky, I think, sticker. So this is at 4 months. Confirmed no more grinding, no more behavioral issues. She actually did very well at school since then, which is quite interesting. This is at 4 months again. We're starting to get more spaces, which is nice. Yeah, this is another thing as well. I'm not too worried about the overjet getting worse because I know we're gonna get some mandibular rotation later on. Okay, so this is at 12 months. I think this was the finish point. There was some rotation, but there was less head tilt. There's still slight discrepancy on the level of the ears, but the eyes are actually level. We're still working on posture and muscle tone, but you could see the jawline is improving. This is the 12 months Ceph. unfortunately, she wasn't biting properly. However, we could see that the point A has moved forward ahead of the nasion, which is the nasal bone. What else is there? Oh, this is the first review. Actually, I forgot we did have a first review with her too. So this is at 18 months. No more overjet. The tongue, I'm not too sure if I'm overly happy with it. She's still doing some postural exercises. Definitely have room for canines. And oh, this is a 12 months, yes. But this is at 18 months. Sorry, that X-ray was 12 months. So it's a little bit out of order. So this is at 18 months. We can see that the muscle tone is significantly better. And the jawline looks so much better. And function, we still need to work on this. Let me see if I can play. So there's still lip bracing, and this is speech. So more controlled with the speech, and she remembers to bite gently before each word. But this is the comparative photo from before and after. I wish I could show the eyes, but anyway. And so much better jawline, I think. And comparative analysis. And again, this was the X-ray that was taken with the bite, not 100% correct. But the point is we could see that the point A has moved forward and better posture too. So in conclusion, by understanding growth, clinician can help guide growth in a more favorable direction. And it is actually collaborative effort because of the environment and compensatory functions that need to be addressed in growing children. So yeah, thank you for the opportunity. I think, you know, it's a very rewarding position to be in, and yeah, I'm very grateful to be able to do what I do. And I'm also impressed with what you do, Renata. You bring so many professionals you know, on board in this space, and yeah, it's great. These children are very, very lucky.
100%. Oh my gosh, I am in awe of these cases. I knew that whenever I came to your office, you were showing me some of the things that you were doing, but my Lord, you know, it's incredible to be able to see these before and afters when you're actually in the field and you understand what you're looking at, especially after this wonderful class. Absolutely incredible. So we have some questions. Do you mind staying a little bit longer?
Of course, of course, bring them on.
Thank you. Do you mind stop sharing the screen?
All right, let me see if I can get the...
Oh, I love that quote. And chat, if you have any questions, also please just put it on the chat box. We're going to be going through some of them right now.
There you go.
The first one was, can you talk more about rotation of the mandible and what might inhibit that growth?
Yes, so number one is muscle function. So muscle. So if you don't have good tone, then, and you don't have your lips closed, and you know, you bite gently when you're not talking or eating, then the mandible is going to run away from you. So that's number one. Number two, it would be very good to unwind those overgrowth of the maxilla by intruding the sixes. You have no idea how powerful that is. And together with muscle function, the rotation will be guaranteed.
Wow.
And obviously you have to clear the path for it. So you need to level your curve for space and, you know, the rest of it, making sure you have space.
Is there hope for adults? Is there any way that you can fix a functional shift on an adult?
A functional shift, yes. Rotation, maybe to an extent. I have not done it Well, I've done only one actually
Mm-hmm.
using Invisalign and not Invisalign, Spark clear aligners and TADs, mini implants. But rehabilitating adults is quite hard unless they're super motivated. So yeah, and also oftentimes they already had protruded maxilla.
Mm-hmm.
So yeah, unless you do surgery and then maintain it with muscle function, there's really nothing that I can see that can predictably bring the maxilla forward without surgery.
So whenever we see tongue tie release done or expansion, even in this class 2 cases, that a lot of these kids are also, the maxilla is also too far back.
Mm-hmm.
Is there something that we can do to change the position of the mandible where it looks a little bit better and it functions a little bit better?
Yes, but your limit is kind of your maxilla. So if you can still bring maxilla forward by protraction, as the
Mm-hmm.
study shown before 12, then yeah, let's do everything we can to bring the mandible forward. So yeah, as I said before, it will be the normal protocol, intrude the 6s and 7s if you have them, normally 6s, and then mandible auto rotation. Make sure your tongue tie is released and you have good function and your nose is working, so we're not working against the natural growth.
I need to do before and after photos of myself, my after photos actually, to kind of have an
Yeah.
idea because it looks like I've had a little bit of an improvement, aesthetic wise,
Yeah.
at least, of my
Yes.
side profile. So I don't
Yes.
know exactly how much forward both things have moved. I'm not sure if they actually, moved,
Yeah.
but it looks better. That's what I know.
Yes.
But I would love to, I need to put them side by side to see actually what happened. However,
Yeah.
whenever we're talking about mandible movement and
Mm-hmm.
functional shifts and rotation, the TMJ, of course, is being impacted by all of
Mm-hmm.
this mandible movement.
Mm-hmm. Mm-hmm.
So, are TMJ issues being triggered by the mandible not being in the right position?
Um, I think it would be a risk factor
Mm-hmm.
because obviously we want the disc to be cushioning, the socket. So if you don't have too much space to begin with, any grinding microtrauma will be more likely to cause the slippage of the disc. So I would say yes. However, I haven't really looked into what studies to back me up. It's more
Mm-hmm.
like clinical observation.
Yes.
Yeah. And look, we always set up our kids in better position. You probably have seen us doing the motor nerve reflex test. We
Oh,
do
I
that in
love it.
kids. We do that in kids as well. But inside the tip, kids, if they pull away when you scratch them, that's a positive.
Mm.
Have you had that done on you? You have, right? So we
The
scratch.
the reflex,
Yes.
yes, it's
Uh-huh.
incredible.
Yeah, so if we scratch the adults, then they respond to it. We press the radial nerve, but in kids, we scratch them, they pull away, they're in sympathetic already. And you set
Wow.
them up in phonetic. And that's
Oh, Dr. Lewis Chang was telling me
yeah.
about the phonetic bite. Can you
Yes.
mention what that is? Because I didn't know what it
Yes.
was.
So it is a functional position. So it's your speaking functional space that has been shown to be the most airway stable. So I do have an article on it written by Steve Olmos. I can email it to you if you like.
Yes,
So
please.
yeah, we set up these kids in that position already. And
Wow.
yeah.
I remember I had to say 61, 62. Is that the one?
Yes, yes,
Yeah,
yes, yes.
very good. That
It's
was so
very
interesting.
useful. Very
Mhm.
useful.
And we start paying attention, even as myofunctional therapists, we're paying attention to what the mandible is doing whenever the patient is speaking. And a lot of
Yes,
times the mandible wants to be right over here, wants to be way forward.
that's right. That's right.
Let's see. Oh, what is the significance of having occlusal coverage on some of these appliances?
Um, I prefer no occlusal coverage.
Mhm.
That's why I use a lot of BioBlock as well. Sometimes I do. So the reason why I like no occlusal coverage is because I want auto eruption. So I would intrude, for example, the sixes, and I want the other teeth to kind of follow. When you have coverage, you can't yeah, like I prefer the body to do what it needs to do. When you have coverage like clear aligners, you can't really predict where it's going to go. So that's when we do our phonetic bite. And
Mm.
yeah, but sometimes I do want coverage, especially those people with quite compressed condyle,
Mhm.
to get them out of pain, because you'll be surprised. Some of these kids do have pain. They just never say it because they didn't know.
Any different?
Yeah,
Mhm.
yeah, yeah.
We were talking earlier about the subluxation of C3, and then you showed
Yeah.
on the X-ray what it looks
Yes.
like. Can you explain what you're looking for in a CBCT and what that means, subluxation of C3, for those who are not familiar?
Okay. So this was actually taught to me by Dr. Steve Olmos. So with cervical vertebrae, they need to be like neatly stacked, like books, like one on top of each other. When one is kind of like out of alignment, we call that subluxation. And that normally happens when a kid needs to breathe, like they need to bring their head forward. Yeah. So it's very interesting when we take CBC. Oh, it looks like the airway is open, but then you see the C3 subluxation. Like, no, it's not really true. They open it
They
themselves so they can
should.
live, you know?
Exactly. Is there a formal name for the cheek line you were measuring? Um,
Oh, the cheek line. That was actually from John Mew's textbook. He did have a very good chapter on reading the face, and that was one of them. It's kind of like a good reference that I show parents. Look, this is where the maxilla is. Instead of pulling the 7, they go like, so many numbers. But
Perfect.
yeah, no,
We usually do
yeah.
this
Yeah, I do.
measurement
I
from
do
you,
indicator line
indicator line.
all the time. We use a Myomate ruler.
Oh, very good. Can you
Yes.
explain why and how the forehead contour changes with expansion and growth?
Sorry, say that again.
The forehead
The forehead.
contour.
Oh, yes, yes, yes. I noticed that with a lot of my class 3 patients. It's interesting. I'm not sure why or how. I would say it's because the maxilla is going forward. But yeah, actually, I'm not sure. It just happens and it's just wonderful. Like these kids were meant to look like that, not the other way.
What are the consequences of not starting expansion early in these children?
Um,
Waiting until they're older for
Yeah.
a
Well,
regular
from
expander.
my point of view, number one, face, and then number two, airway, and then number three, gummy smile. Yeah, I'm a bit vain, so I want these kids to grow like, to their best potential. And of course, not all families are able to commit to that because it's a lot of work. And then when they need to wait, then we just support them that way. But I tell them, look, it may impact on your airway and TMJ and so forth. Yeah.
Very good. I know, talking about being vain, I did Botox to
Did
get rid
you?
of my gummy smile, but I don't like it. It feels like I'm fake smiling now. It's too
Oh, this is why we intervene early, by the way.
so you don't
But
have
it's
to do
okay.
Botox. But it's gonna get a little bit better as this starts going away. But oh my Lord, I have to try it. If my patients are doing it, like I need to try all things.
Your patients do it.
Mhm.
I'm not
Even
as game as you.
I mean, it bothers a lot of people, and you guys know how much I love taking selfies, and I'm always taking photos. So, my gummy smile really bothered me, but I'm so not used to not having it now. And of course, as a myofunctional therapist,
Mm.
I'm used to using this muscle.
Yeah, Yes.
And another thing that we don't talk about enough, it's the movement of these muscles and these cranial nerves every single time that you're using these muscles also for facial expression, and how
Yes.
just changing your facial expression, it can change how you feel. And I've been noticing that
Mm.
since I can't move this, my smile doesn't feel the same to me. I don't feel
Oh
happy when I smile. Isn't that weird?
no. Very, but that's interesting.
I know there's so much still that we don't know, but I noticed that I was like, oh my gosh, it's so weird because it looks like it feels to me like I'm fake smiling, even though I feel happy, but I can't
Oh.
do it. It's weird. Anyways, that's not for another talk. Why do lower incisors compensate to meet the upper dentition? What is the mechanism for that?
It's for mastication, I would assume, and because the tongue doesn't have enough room too, so the tongue was thrusting in this kid, and yeah, the poor incisor just bear the brunt.
Yes.
Yeah,
Can
yeah.
you please point out straight line maxillary suture as a positive sign of growth candidacy? So somebody a good candidate
Um,
for,
yeah. So let me go
because I know
back.
you had different types of sutures from that research you showed.
Yeah, I can send that paper too.
Thank you.
Do.
So would this X-ray to look at the suture be a good guideline to see if the patient can still use an
When,
RPE?
yeah, if they are older, if they're kind of like 6, 7, 8,
Mm-hmm.
then yeah, then you know they will be okay. But when they kind of 11, 10, that's when you have a look. So in this image here, you could see it's still straight. Both the patient I showed you are actually still in the growth stage. The scallop one will look like lace, and then it will be like high density around them. And where's the other one? Yeah, we are very lucky we have iCat, so we don't even think twice. This
It
one
is
is
the best.
starting to be scallop, actually.
So we can change. I can't see what you're seeing.
Oh, sorry. Oh my goodness, I forgot. Let me see. Share skin. Okay. Okay, here we are. So this one is a little bit lacy from the posterior, and
Mhm.
ossification actually starts from the posterior to the front. I'll show you the other one. The other one is still straight, even though she's a bit older. Here we are. So that's a bit more straight line.
Okay. Wow. That is so neat.
Yeah. Like, if you know growth, you can have protocol and you can bespoke it to anybody, and it's easy. It's no brainer.
Right. I have a 16-year-old that had
Mm.
the RPE with the Invisalign
I
palatal
see.
expander and beautiful suture split. And the
Yeah.
13-year-old sister, that's younger,
Mm.
female, didn't split at all.
Mm. Oh, there you
Very
go. We
interesting.
need iCat.
Yeah, 100%. Let's see if I have a couple more questions. When you say that the patient is a horizontal grower, are you always referring to a class 3 presentation?
No, we can have horizontal grower in class 2 as well. Yeah, just the numbers that Ricketts a long time ago used as normal. So that's, I guess, just how we communicate. But now we know it's the face will tell you more than the numbers, and the muscles will carry more than what you can do. So to be honest, all this movement, they're very easy. Maintaining it and rehabilitating muscle is harder. So kudo to OMTs like you, my goodness, like, what would we do without you?
Yeah, well, we
Bad
all work
result. That's what we
together.
get.
It goes both ways, you know. We can only get so far with our patients, but we can't do what we need to do without you guys addressing the skeletal structure. Which professional in Australia is the one who typically recommends dietary modifications?
Very interesting. In our clinic, Dr. Chen and I normally just make the recommendation. Sometimes the body workers can double as nutritionists, like Polly, who referred to. She's actually qualified nutritionist. The dietitians that we refer to, unfortunately, they still stick to the old paradigm of, grains and dairy. And we know from studies that they congest. So yes, it's very interesting. We're hoping more nutritionists will be on the same page in this space and can collaborate with us.
Oh my goodness, fantastic. At what point do you find it's most beneficial to refer for myofunctional therapy?
From the start.
Yes, very good.
For me, it's from the start. The quicker you rehabilitate, the easier it is. We create the structure and then they all move in and it's just happy life.
Wow. Amazing. Last question. After the 18th month mark, when is the next time you'd see the patient, the last case you showed? What can that
Yep.
jawline in the second case improve further? And third part of the question, can that occur with natural growth at her age?
So we want natural growth, right? This is the whole point of it. We want to touch a little bit and then growth takes over. So from the review point of view, it's more for me to make sure that the teeth fit. And if the muscle's slacking off, either off to the body worker who does OMT or speech pathologist that does OMT. I would review them normally every school holidays. In here is every 3 months. Sometimes 6 months if I think they're quite stable from functional point of view. What can help the jawline to improve further? Then obviously, good muscle function. So nasal breathing, good diet, good chewing. And what was the third part? I think there was a third part of the question, or was that all?
After the 18-month mark, when's the next time you'd see her? What can help that jawline in the second case improve further? And can that occur with natural growth at her age?
Natural growth as in if you didn't do any expansion? I don't think so.
Okay.
Because there's no way the tongue will go up there. And there's no way she would be able to breathe without the ENT intervention and the breathing exercises. So unfortunately, life would be so different if we didn't do anything for her.
I have a couple patients right now. They already had their first phase of expansion, but they're still a class 2. So that's what the mom was talking about yesterday.
Oh, I see.
Do they still have the chance of having some mandibular movement forward with natural
you have to guide
growth spurts?
No, you have to guide them. You have to guide them. I believe you have to guide them because there's a reason why you have expansion and then the lower jaw doesn't follow, right? There must be a reason. So we have to address the root cause. Could it be the tongue tie? Could it be the muscle function? Could it be the breathing? Yeah.
Oh my goodness. What an incredible session. Thank you so
thank you.
much.
You're so kind.
Seriously, thank you so much for your time with us. And every time that we have a Thursday Night Live that we call them on Aries Circle, even though the topics are similar, we already have over 200 of them, but every single talk is so different and we learn something new. So thank you for sharing your expertise with us, for helping us spread knowledge throughout our colleagues and improve collaboration and sharing and connecting with one another. So thank you for being here. It was a pleasure to meet you. And
You're most welcome.
Thank you. How can people reach out to you?
I do have an Instagram, so please follow me.
Perfect.
It's at Dr. Yudith K. I do have a Facebook page. I believe my website is being rejigged at the moment because my husband decided to get a domain for me. So good on him, my IT guy. I'm in Sydney in Meadowbank with Dr. Louis Chan. So feel free to shoot us email. I believe you have my email too. So you're happy to connect with anyone. I'm so excited we have this for these kids now. This is what I love the best about my job, helping these kids to reach their potential. because I didn't have that privilege.
Botox over here. Hello.
Exactly, right? Exactly. I'm still doing myofunction, but anyway.
We are our own patients too. Thank you so much for
You're most
hanging out with us.
welcome.
That was wonderful. Have a wonderful night. I think it's nighttime there already.
It's about 4:27 a.m.
I had no idea. Oh my goodness, we're gonna have to talk about that time change.
It's
Well,
okay.
go get some rest. We'll talk to you
okay.
later. Thank you.
Thank you for the opportunity. Bye.